and thank you to everyone for joining us today. On behalf of Jagsonpal Pharmaceuticals Limited, I welcome you all to this webinar on infertility, filling the lacunae with theme, learning the continuous process today. This webinar is in an initiative of Lalita Memorial Hospital, Rewari, in association with Rewari Obs Gyn Society, supported by Haryana chapter of Indian Fertility Society with academic partner Naari division of Jagsonpal Pharma Ltd, makers of Cystelia-M, Divagest range, and our newly launched LycoRed-M tablets. We proudly announce the launch of LycoRed-M tablet for male infertility. LycoRed-M tablets of natural lycopene are fortified with N-acetylcysteine, enriched with coenzyme L-carnitine. We now invite Dr. Seema Mittal, Director, Lalita Memorial Hospital and Infertility Center, Rewari, past President, Rewari Obs Gyn Society, and Treasurer, Haryana Chapter of Indian Fertility Society. Ma'am, please kindly initiate this program. Thank you.
Thank you, Mijit. Thank you, Team Jagsonpal. And here we are with third episode of Learning the Continuous Process. Very good afternoon to all of you. And as it's a continuous process, we are trying to fill in the lacunae, and we are really thankful to our speakers for the evening, and especially Dr. Bela, who is such a wonderful teacher, to FOGSI. And there are not enough words in dictionary to describe what a personality she is. So may I request our Honorable President of Rewari Obs Gyn Society, Dr. Alka Yadav. First of all, thank you, Dr. Alka, so much. In spite of being so busy, she has come to join this webinar to welcome our esteemed speakers. So over to you, Dr. Alka, to introduce the speaker of this special event of today, the third episode, Dr. Bela Bhatt. Over to you, Dr. Alka.
Hello, good afternoon, everybody. It is a great pleasure to be with you all in this another session on infertility. And I take pleasure in introducing Dr. Bela Bhatt. She is the Chairman FOGSI Imaging Science Committee for 21-25. And she is a person of OB-GYN who is very much interested in fetal medicine. And she is working as consultant at Women's Hospital and Fetal Medicine Center, Andheri, Mumbai. She is also a fetal medical consultant at Dr. Baba Saheb Ambedkar Memorial Central Railway Hospital, Mumbai. And she has a FMF certification of sonologist for Fetal Abnormality Society and for nuchal scan. She's a life member of the Society for Fetal Medicine, Joint Secretary for AFG, Mumbai.
Thank you so much.
I welcome you for your talk.
Thank you so much for your kind words. And as I always say, now the Rewari Society is almost like a family to me. So it's my pleasure to, in fact, kind of join this webinar and meet you all, at least online, and share my views on the topic. So without much ado, I think, first of all, thank you so much, Dr. Seema Mittal, who's been a dear friend and has always been there to invite me for such wonderful webinars. And she herself is doing a wonderful academic activities and professional activities. So congratulations for the same. And also thankful to President Rewari Society, Dr. Alka Yadav, for always being there and supporting such academic activities, and for having me here today. Thank you so much. And with this, I think we will start with the topic. So I'm going to talk today about second trimester anomaly scan, See Me Better. So in the introduction, they said it's an infertility webinar. So then once the patient conceives, we are always worried about the baby, how the baby is. We know now we have nuchal scan, then we can see 50% of anomalies. But then the real second trimester anomaly scan between 18 to 22 weeks is one where you have to look at the baby closely, because that's the time when you'll be able to pick up almost 90% of structural anomalies. The various guidelines for looking at the anomalies in the fetus, out of which ECOG is the one which we always follow as an international guideline. Now, what are the main aims of second trimester anomaly scan? So basically, we look at the fetal number, viability, fetal age, size, biometry, and of course, fetal anomalies, anatomic structures, and then the environment as well, that is placental, Lyca, uterine wall, and adnexa. Now, when to perform? The best time is from 18 to 22. Now with the amendment of law, the limit has extended to 24 weeks for some of the lethal anomalies or severe anomalies. But still, I would consider the best time would be around 19 to 20, because if there is something, if we want to work up and all, we have some 3-4 weeks in hand. So 19 to 20 weeks would be a good time to do anomaly scan. The sensitivity of detection of anomalies is obviously far superior at 22 to 24 weeks, because some of the structures of the brain, heart have developed better. We can see better. But again, remember, even in this 18 to 24 week scan, some of the anomalies may not be evident, because some of the anomalies evolve in the later second and third trimester. So never assure the patient that we are going to rule out all the anomalies. That's one thing. Ultrasonic equipment, we all know we need the better the ultrasound machine, better the resolution, we get better images, and of course we can look at the structures better. It should have the adjustable acoustic power, freeze frame capabilities, electronic calipers, and capacity to print and store images, as well as regular maintenance and servicing. This is all very, very important. If you are already using a machine, you will realize how important all these factors are. Image optimization is also extremely, extremely important. Now, how much time should you spend for an anomaly scan? Well, remember, detection of anomalies is proportionate to the time given for the examination, but minimum 20 minutes is what you have to give if you really want to look at the baby properly. Then, as per your time and convenience, you may extend it to 30 minutes, 40 minutes, right? And if at all there is an anomaly, of course, we'll take an extra time to rule out any other structure anomaly or soft markers, etc. Not only that, if you are doing scans on your own, you know that if the patient is obese, if they have previous scars, maternal habitus, then you may take longer time, because you'll not get proper views to look at each and every section and planes in the fetus. So it depends on many, many, many factors: your training, your machine, your fetal position, LycoRed, even oligohydramnios, you'll not be able to see the things. So it's dependent on many, many, many things. Now, as I always say, what we have learned in our undergraduate days stands true today also. If you want to pick up some abnormality, first you should have seen many, many normal and fetuses. Then you'll be able to pick up that, oh, this is abnormal, right? So look at, if you are training yourself or you're taking some training, then better to have a look at all the normals. Then you'll be able to pick up the abnormals from that. So that's a basic principle. So as I said, issue of basic training tells us that these 20+2 planes approach is a very good one approach to rule out majority of the structure anomalies. So what is it? 2 is the sweeps and 20 planes. We'll come to that soon. You have to magnify the images. Cine loops are better than the images, especially heart. Documentation of all 20 planes is important. And the idea behind these planes is that each fetal structure has multiple planes, like the face has the sagittal plane, a coronal plane, and an axial plane. So we need to look at the face in all 3 planes and many more structures in the fetal body. We have to look for the normal, and then we try to differentiate from the abnormal. Now, which are the 2 sweeps that we start with? We start with a survey sweep at the beginning. And what do we look at it? In that, we do eyeballing. We look at the number of fetuses, whether it's singleton, twins, triplets, lion presentation quickly, viability, look at the heart, location of placenta, amount of fluid, fetal biometry is the next step. So you get an overall idea about the pregnancy, right? And whether there is something which is grossly abnormal that, hits your eyes. So that's how we start with a survey sweep. As far as the biometry is concerned, we look at the BPD, HC, AC, FL. Again, remember, it's not necessary to first go and take the biometry and then look at the structure. No, you have to be very intelligent when you are doing a scan. First, you have had a survey sweep. See if the spine is up. First, I'll finish the spine, looking at the kidneys, and then as the fetal position is there, I'll go and look at the structures, which one is the easiest, because you may not get that position again. If the face is in the front, then I'll look at the sagittal section of the face, look at the nasal bone and the profile and the cardia first, and then look at the other structures. So it is not necessary to go step by step, but look at the position of fetus and decide which sections are to be taken first, right? As far as 20 planes are concerned, these are various planes in spine, head, thorax, the abdomen, pelvis, limb, face, and then the overview sweep. But I'm not going into details of theory because I'm going to show you each and every structure in my images and my video clips. Okay. Now, as we start, as I said, first we have had a survey sweep, and we always look at the fetal cardiac activity, and so that we also know that it's a viable fetus. And the patient always loves to look at the heartbeat. Patient loves to hear the heartbeat of the baby. So show that first to the patient and the relative that look, this is the heart rate of the fetus, and then we go ahead with our anomaly scan. So let's start with the head. As I told you, no need to go in the same fashion, but I'll tell you from the head to the head down. Now, in the head, we look at three important planes, that is transventricular, transthalamic, and transcerebellar plane. So as you can see in the video clip, we start right from the top, that is, we look at the falx cerebri, then we go down. The next will be transventricular plane, as you can see here, and then in the same plane, you can also see the cavum, septum pellucidum, and the anterior horns of the ventricles, which is the anterior complex. So you see the lateral ventricle here, you see the cavum, septum pellucidum here, and then as you go, the video is not playing. Okay, I'll just show you. So then you go down, then you'll get your transthalamic plane. Both the thalami you will be seeing in the center. Then you go down, and then okay, two thalami you can see, and then you go down and tilt your probe caudally, posteriorly, then you will get your cerebellum here. Cerebellum, the cisterna magna, and the nuchal fold thickness. So that's how three planes, which are very, very important, which are taken here. Now, these are the images. Now, this image, this is again an image which is showing you the lateral ventricles of the posterior horns of the lateral ventricle. Now, it's extremely important for us to take certain measurements also in these planes. So this is transventricular plane, in which we are going to take, you can take your BPD either in the transventricular plane or in the transthalamic plane. This is a transthalamic plane. So you can take it in either plane. Now, we usually from the FMFUK trained people, we are used to take BPD in the transventricular plane, which is out-to-out measurement of the transparietal diameter, biparietal diameter, and then you take a occipitofrontal measurement. So that's your BPD and OFD that you've taken. And third important measurement is always atrium of lateral ventricle, because this is taken at the occipitoparietal sulcus here and perpendicular to the lateral ventricular wall, because if the measurement is more than 10 millimeter, it is ventriculomegaly, which is one of the soft marker for trisomy 21. So we look at 9 soft markers also when we do anomaly scan. We look at the structure anomalies, we look at the soft markers. So one of the soft marker, important major marker, is ventriculomegaly, which you see in this plane. Then comes your transthalamic plane, of course, very, very important. Again, in that also you should be able to see your corpus, cavum, septum pellucidum, and anterior complex. And then comes your transcerebellar plane. Hope the marker is seen, right? So this is this cerebellum, the dumbbell-shaped cerebellum. So as I said, always remember, have these images imprinted in your brain. The cerebellum has to look like this, like dumbbell, and you should be able to see the two hemisphere of cerebellum and the vernix in the center. Now, the thing is that we take this transcerebellar diameter here in this, then we take the cisterna magna measurement, which is from the cerebellum to the occipital bone, and then we take the nuchal fold thickness, which is from the occipital bone to the skin. Again, this would be your nuchal fold is a major marker for trisomy 21 if the measurement is more than 6 then it is called a high nuchal fold thickness. Again, a very important marker for trisomy 21. So as we look at the structures, we look at the structure anomaly as well as the soft markers. So these are three important planes in the brain as we see. Then we go to the face. Again, as I said, you have to look at the transsagittal, the coronal, and the axial plane. So in transsagittal plane, we look at the nasal bone. We always take the measurement of this, and then we have to see whether it's absent or hypoplastic bone. And there are the charts available to look at the measurement, or softwares available which will tell you whether it's less than 2.5 centile when we call it hypoplastic. And again, that's a major marker for trisomy 21. You look at the nose and lips. This is very, very important to rule out cleft lip, right? So that also you can see in the coronal plane. And in axial plane, you look at the both orbits in the axial plane with the lens, as you can see here in the image. Again, you can, in this clip also, you'll be able to see both the orbits as we see in the axial plane. And then as we go down, we'll be able to see the hard palate and the upper lip. So these images, these planes are going to rule out cleft lip, cleft palate. Again, if the baby opens the mouth, it's a good practice to store this image because it will rule out your cleft lip, right? So cleft lip, cleft palate, we have ruled out. Major anomalies related to eyeballs, we have ruled out by looking at, and it's important to document these images. Keep it in your machine as well as give these important images to your patient as well. Then we go to the spine. In spine, again, there are three planes. We look at the sagittal plane, in which you need to look at the spine and the complete skin covering it. Now, in spine, we have to be very, very careful that the lower part, see, if you can't see the lower part, you can't just leave like that. You have to go to the lower part of it and take proper section, because there are sometimes subtle small spina bifida here which you may miss. So documenting a good proper section of the lower spine is also equally important. You also need to see the spine in this coronal plane and axial plane, right from neck, fetal neck, cervical vertebrae to down till sacrum, to try and kind of rule out any small subtle spina bifida which is there. Okay, so that's how we look at the spine. As we go to the chest, in there will be four planes. One is four chamber views with the lung, LVOT, that is left ventricular outlet, RVOT, right ventricular outlet, and three vessel trachea view. Now, whenever we look at the heart, first thing we look at is the situs. Where we start with the abdominal situs. First, we decide whether the stomach is on the left side, and that you can check by kind of imagining yourself in the fetus and try and decide which is the right and which is the left, and then try and see whether the stomach and heart both are on the left side. And then you have to document this, that the stomach and the apex of the heart are on the same side, which will prove that it's a situs solitus. So it starts from the abdominal section like this, as you can see in the clip. Then you go up in the thorax. You'll be able to see the four chamber view of the heart. You can see the two pulmonary veins entering in the left ventricle, left atrium. Then you will see the LVOT, then the RVOT, then the three vessel view, and then the three vessel trachea view. So that's how in the clip you can see it starts from the abdomen and then it goes up to the three vessel trachea view. This is the still image of four chamber view, where you can see two pulmonary veins entering. This denotes that this is a left atrium, and in the right ventricle you should be able to see the moderator bend. This is what denotes it as a right ventricle. So you have proved that this is the left atrium and this is the right ventricle. So you know that there is no discrepancy between these chambers. And then as you go up, you look at the structures. Again, color Doppler is extremely important because you have to look at the flows, whether there is any regurgitation, whether there is any kind of flow abnormalities in the heart. So again, in the clip also, you can see an images. These two are very, very important. The inflows from atria to ventricle, they have to be the same, and there should not be same color, no regurgitation. And this V is extremely important. That is formed by the aortic arch and the pulmonary and the aortic arch. And towards the left of trachea. This proves that the connections are normal, the arches are normal, the flows in the arches are normal, and that you can see in the clip as well as in the still images. So documenting all this, when you document that the 4-chamber view is normal, the inflows, outflows, the LVOT, RVOT, and the 3-vessel trachea view are normal, these 4 views will rule out major 90% of structural anomalies of the heart, right? So this is what you have to, of course, there's a lot more in fetal echo that we look at, but then major, look at the situs, start from the abdomen, go till the 3-vessel trachea view, and then this is how you kind of try and find out whether there is an abnormality in the heart. So these are again few images in the clip. This is the left ventricular outflow. This is the right ventricular outflow. This is 3-vessel trachea view. This all you have to document when you are doing a and it doesn't take much time. Only thing which is required is a learning curve to get a good 4-chamber view and the good 3-vessel trachea view. So yes, it needs some learning curve, and then but you have to, if you want to do it properly, you have to take proper training to get these views right, so that you rule out the anomalies related to heart. Now, documenting a ductus venosus is optional, but we always do in our anomaly scan. And the flow, it has to show that a positive A wave is there, and it's connected to along with the hepatic vein in the vestibule, and is entering in the inferior vena cava. So once you show this, the ductus venosus abnormalities are also ruled out. We go to the abdomen, where, of course, when we have to take the abdominal circumference, never take your abdominal circumference if you do not see stomach in your abdominal section, because again, presence of stomach will rule out some of the upper GI anomalies, right? So you have to always show the stomach, and in the abdominal circumference, when you look at the stomach, it should show the stomach and it should show the hepatic. You can see this umbilical vein entering into the hepatic flexure, but then this is what has to be seen. The umbilical vein should never be seen in your abdominal section. And when you see the stomach and the liver and this portal vein, then this is and kidneys are not seen. This is a correct section for your taking your abdominal measurements also for your abdominal circumference. So then we go for the antero-posterior diameter of the abdomen and the transverse diameter of the abdomen. And you can either take it this way or the ellipse way, whichever is, I am more comfortable with this APAD and TAD. So I take 2 measurements, and then the machine will calculate the abdominal circumference. That is one section. Then this is the section which shows that the cord is inserted into the abdomen properly. There is no, here we are ruling out 2 anomalies. If we see a good cord insertion like this entering into the abdomen, we rule out the exomphilos and we rule out the gastroschisis. So once you document these normal sections, you are ruling out one by one the common structural anomalies. And on color Doppler also, you can document that there is no gastroschisis or omphalocele at the entry of the umbilical cord. Now, not only that, you also have to document in the axial section, the kidneys in the abdomen this is the pelvis of the kidney we measure in the axial section, because if it is more than 4 millimeters at 18 to 22 weeks, till 10 millimeters, it is called a mild pylectasis or mild hydronephrosis. Again, this is one of the markers for trisomy 21, right? So as we look at the structures, also we simultaneously look at the soft markers. These 2 renal arteries will prove that both the kidneys are present. Okay, you also have to look at the renal arteries and the kidneys. Another section in the abdomen, actually lower down in the pelvis as we go down, is the 2 umbilical arteries, because they are flanking the bladder, and then they go into the umbilical cord. So this will prove that this is a 3-vessel cord, 2 umbilical arteries and 1 vein, and there is no single umbilical artery, because whenever there is single umbilical artery, there can be associated cardiac, GI, GU anomalies. So you have to look at the other structures carefully. So again, you have to document that this 3-vessel cord is present, right? That's about the body. Then we come to the limbs. Now in limbs, you have to look at both femurs and both legs, 3 segment relation with the foot, both hands, 3 segments in the hand and relation with the hand and forearm. So we take the femoral length measurement and we look at the all three bones in the legs, and we always show the relation of the leg with the foot. This will rule out your CTV, right? And you always take an image of foot. So this is what you look in the legs, and in the hands again, all three segments, the arm, the forearm, and the hand, and try and show if the baby shows open hand. It's good practice to document all these. Now we all know how important it is to look at each and every structures, but also at the hands and the legs, because one of the obstetrician was sued for a missing limb with some 1.5 crore compensation. So of course, each and every structure anomaly has to be looked at carefully, but then documenting these things are very, very important. These are some optional sections, but we always we show that there's a stomach is in the abdomen, the small bowel, the bladder, the diaphragm. We always show that it rules out some of the anomalies. So first we looked at the normal structures, and then I'm going to show you some of the abnormalities in the fetus. As I said, I always want you to look at the normal structures first, then you'll be able to pick up the abnormalities. But once we have, as I said, once we have looked at the fetus, we always look at the cervix. We take the cervical length at anomaly scan in all the patients by transvaginal probe, and that's a gold standard, because if the cervical length is less then 2.5 centimeters at 18 to 22 weeks scan, that's going to put your patient at high risk for preterm delivery. So this is something that is mandatory that we take in an anomaly scan. Not only that, you mean uterine artery, we take the uterine artery PI on both the sides, and always take a mean uterine artery PI, because again that is going to tell you about possibilities of this patient developing preeclampsia or fetal growth restriction. Of course, we look at it in the nuchal scan, but we always also look at it at anomaly scan or 18 to 22 weeks scan. We look at the environment, that is a placental location, where it's low-lying, anterior, posterior, the amount of LycoRed. If it's low-lying, on transvaginal, we'll try to find out the distance from the internal os to the lower edge. And if it is less than 2 centimeters, then it is definitely placenta previa, right? Of course, we have to then follow up in the second trimester, late second, third trimester, to see if at all there is some placental migration. But we always document if it's a low-lying placenta and then follow them up properly. Now, a checklist when you are doing scan is must, because as I said, we are not going to go from top to bottom. We'll be optimistic. We are going to be opportunistic. We'll take the opportunity as the fetus shows us spine, we'll see that first. Then if it shows face, then we are going to see that first. So you may miss some of the things and you feel that you have finished your scan. So you must have a checklist with you, or some assistant with you with a checklist who takes that, yes, these structures have been seen, and so that you do not miss when you are actually doing an anomaly scan, you realize that you sometimes may miss some of the structures. So you must have a checklist at the end, so that you know that if you have missed something, go back and look at the structure. Once you complete your scan, your comment at the end should have clarity as to if at all there is some structure anomaly, some soft markers, what kind of anomaly it is. Mention about the growth centiles that we always tell. Never mention that it is so and so weeks on scan. The weeks are decided by your dating scan, which has been done. So it is at present maybe 20 weeks, 2 days. And then what are the growth centiles as per that weeks of gestation, which your machines will always give. And you have to mention whether it's in proper growth, 10 to 98th centile or not. Mention what all structures you have seen. So as I said, many a times because of obesity, previous scar, you may not be able to see. Because of improper position of the fetus, you may not be able to see. You may have to tell the patient to wait outside, again call after some time. Sometimes you have to call the patient in the evening or next day, because the patient maybe if the baby's face doesn't turn up, I'll not be able to get the sagittal section of face. I'll not be able to see the heart properly if I don't get the apical section. So either you call the patient back, and if the patient is not ready to come, you'll have to mention in your scan that because of the improper position of the fetus or amount of LycoRed or obesity or whatever reason, so and so structures could not be seen. Because what you have not seen, you cannot comment that it's normal, right? Neither it is abnormal. So you have to see, mention if at all you couldn't see something that this could not be seen. And you can call patient back always to look at that structure. Mention the reason also why you couldn't see it. Mention about the placenta, you may not be always able to give a diagnosis, but you should always give what all findings are there on anomaly scan. The disclaimer also should not be very big. Now, I have already mentioned that the order is not something which has to be maintained. Be opportunistic and look at the two planes and two overviews. But it's important that any appearance that you are looking at, if you are beginner or you are training, then if you feel that something which is not looking normal, but you are not able to diagnose, then it's better to refer to an expert so that the patient also gets clarity and we can help our patient better. So with those normal appearance, now I'm going to show you some of the cases, some of the anomalies which are picked up at my center. So this, as I told you, this in the center, I'm showing you a normal image, right? So I told you, remember this dumbbell shape of cerebellum, right? This has to be documented. Now in this particular patient, can you see that dumbbell shape here? No, there is a posterior fossa cyst in here, and these are two cerebellar hemisphere, but I cannot see the vermis of the cerebellum here, right? So this is the posterior fossa cyst here. And in the whenever there's an anomaly, we try and look in the coronal as well as the sagittal section. And here we can see that the vermis of the cerebellum has been pushed up by these posterior fossa cyst. Here also in the coronal section we can see. And so this is a Dandy Walker malformation, right? Where there's a posterior fossa cyst. And it's very obvious that there is vermian agenesis here. So it's a serious CNS anomaly where you have to counsel to the patient that the baby is not going to be mentally normal. Another case where again we always look at the shape of the head. So as you can very clearly see here, there is frontal scalloping of the frontal bones. Not only that, there is if you look at the cerebellum again, you don't see the dumbbell shape. Here it is in the bend into the banana shape. Why? Because there is, as you can see here, a spinal anomaly, and wherein it's an open spina bifida with scoliosis, where kyphosis is also there, because of which the the CSF fluid has drained out. So the cerebellum has been pulled down, and that's the reason why there is a banana shape of the cerebellum. And that's a typical open spinal defect with the CNS central brain changes in the cerebellum and midbrain. It's an Arnold-Chiari malformation, right? So these are if you have seen normal views, then of course you'll be able to pick up all these abnormalities very well. Now again, as I see, he said in the face, you will be able to make out the nasal bone in the sagittal section. Can you see it here? No. So this is an unossified nasal bone or absent nasal bone. We usually prefer to call it unossified. Not only that, in this baby, there were echogenic intracardiac focus, and there were multiple, two at least we can see here. These were the markers, soft markers which were present. So the patient was counseled that these are the markers for trisomy 21 and the chances are high. So we have to do amniocentesis. So amniocentesis was done, and this turned out to be a trisomy 21 baby. This is another case where there is, as I hope it was a dialogue, then I could have asked you and we could have interacted better. You can see a double bubble here, right? Stomach and another bubble medial to it. This is a double bubble, which is again one of the markers for trisomy 21. So again, in this particular case, the patient was explained that we have to do amniocentesis and do genetic testing to rule out some of the chromosomal problem, and amniocentesis did show a trisomy 21 in this particular case. Another case where if you can see, this is the upper part, lower part, bladder, This is a diaphragm. You can see the stomach has gone up in the chest behind the heart. So this is a case of diaphragmatic hernia, where you see not just the stomach up, but the liver, the small bowels, everything. This is a chest, the axial section of the thorax, which is showing stomach, liver, small bowels, which has pushed the heart to the right side. So the heart has been pushed to right from left by these herniated stomach, bowel and liver. Again, we have to discuss it in detail, because prognostication depends on what is the volume of the contralateral lung, and then we have to compare it with the head circumference. There are ratios to kind of prognosticate, but that needs a detailed talk on the same topic. Some of the cardiac anomalies, as I said, if you have seen normal, you know this is something abnormal. I don't find this ventricle. This is the left side of the fetus. I see a normal right ventricular chamber, but the left ventricle is not normal. So there's something abnormal. I see only one vessel in the 3-vessel view. So what's wrong with this fetus? I put on the color. I see a flow only across the tricuspid valve, but nothing across the mitral valve. So this is for sure a hypoplastic left heart syndrome, wherein the left side chambers have not developed, and we see only flow across the tricuspid valve, and we see only the pulmonary artery and not the aortic. Again, it's a severe congenital cardiac anomaly. So if you know what to look at in your 4-chamber and color Doppler, you'll be able to pick up these anomalies. This was a case where again, you can see a typical enlarged bladder, which is known as megacystis, with a dilatation of proximal urethra, which gives a typical keyhole appearance of this bladder, and that's because of the obstruction down in the urethra. So it's a lower urinary tract obstruction. This proves that two umbilical arteries are flanking. So this is nothing but bladder. So this is a keyhole bladder with severe oligohydramnios. This was a severe kind of lower urinary tract obstruction which was picked up. This is a case of in the limb. As you can see, when you see the tibia, you should not be able to see the foot. If you see the foot and the tibia in the same plane, that means there is some abnormality. This is a CTEV, congenital talipes equinovarus abnormality. And see, remember one rule of thumb: whenever you find any anomaly in the fetus, structure anomaly, we have to rule out the chromosomal or a genetic cause, right? Because these days genetics is evolving like anything. We have various tests available. If not in the karyotype, we have microarray. If not in that, we have whole exome sequencing. Step by step, we can offer the test. Of course, it's difficult to counsel the patient. It's expensive right now, but day by day, the cost is reducing. At least amniocentesis followed by FISH and karyotype is something which can be offered, rules out common anomalies. Some people also prefer FISH and microarray. Depends after counseling and with counseling with the geneticist. But see, terminating a severe anomaly is not the answer. Even if there's a lethal anomaly or severe anomaly, always counsel the patient to go for a genetic testing, either antenatally with amniotic fluid, or if you are terminating for a lethal anomaly, then at least the tissue of the fetus should be sent to the genetic lab for testing, because not just to find out the cause in this pregnancy, because some of the anomalies will have genetic problem, will have recurrence in next pregnancy. So it will help you to prognosticate in next pregnancy if there is at all any genetic cause for the same. So it's very, very important. If the patient is not ready for the kind of genetic testing at that point of termination, save the DNA in the genetic lab. They save it for 2 years in 2,500 rupees, and at later date it can be tested upon for any kind of anomalies. So these are important points. As far as this, I see 30 minutes is not a time when you can discuss about all anomalies. There's so many things to talk about, but in nutshell, I wanted to tell you that look at the normal structures properly, have a checklist, try and find out the common structure anomalies. If you have any doubt, please refer to a higher center. And the ultrasound is generally safe, but then we should always look at the LRA principle. That is, it should be used as low as reasonably achievable. And medico-legally, always tell that, see, some anomalies may be missed even with the best ultrasound equipment, and hence, because there are so many factors, as I said, fetal position, like maternal obesity, baby's spine, anterior, posterior. So if you're doing routinely, you will find out that so many things, you may not get the ideal plane in some babies. So always say, how much you have seen, you should mention. What not seen, you should mention. And tell at the end that we can rule out 90% of structural anomalies at 18 to 22 weeks. But there's some evolving anomalies because the fetus is still developing. Some of the anomalies may come up at 6th, 7th, 8th month, which we can't pick up now. So patient always want to hear from us, "Sab theek hai na, baby theek hai na?" Said 90% I can assure you. 100% is always at birth, and we should always, as the baby grows, 6, 7, 8 months, also we need to have a look at it. So in nutshell, I have tried to put what an anomaly, structure anomalies scan is in the second trimester. Hope it will help you to some extent. And I will always wish that every obstetrician tries to learn ultrasound on his or her own, because each and every patient of ours needs ultrasound for management. Of course, these higher end scans need proper training, lots of training, lots of learning curve. So only if you have taken training, you have to do this. But at least we should try and train ourselves. Thank you so much.
That was very wonderful, Dr. Bela. A very precise and crisp description of the anomalies which we should, all obstetricians should look for at least. Even if you are not mentioning them, but we need to be very sure for the patient, because हर patient का एक ही सवाल होता है कि सब कुछ ठीक है ना, बच्चा तो ठीक है ना. That is a typical mother who is asking. वो unborn child अपने womb में लेके घूम रही है, उसको बाहर आएगा तो उसको उसी बच्चे को पालना है. तो she has to be very sure that everything is right. That was a very nice talk, very, very nice description. Thank you so much, Dr. Bela.
Thank you, Dr. Bela. This was such a systematic, elaborate, exhaustive, and I will say the most complete presentation. And next time, surely we are going to have 1 hour presentation, because as of now, like, "Tumi mera mandir, tumi meri puja." It was such a wonderful presentation.
Only thing, there's so many things. So let me see.
But emotions behind your presentation make you a very special person. Thank you so much. And we have our next wonderful speaker, Dr. Venugopal. And to introduce Dr. Venugopal, I will request our most honorable sir, our teacher, our guide mentor, Dr. Brigadier Sunil Takyar sir. He's retired OBGY from Indian Army and professor at Al Farah School of Medical Sciences. And he has many awards. One is Chief of Army Staff Commendation and GOC in Sea Northern Command. Sir, over to you to introduce our next speaker with the most needed topic of today's infertility specialist. Over to you, sir.
Thank you, Seema. You have been always wonderful with your words. And it's nice to be introducing Dr. Venugopal, the Executive Director in this center at Palakkad. I hope I am speaking the name right. Otherwise, my wife will kill me. She is a Malayali again. Okay. Then a trained individual, a gold medalist MD, the Secretary General of Kerala Federation of Obs and Gynae Society and of the Kerala chapter of Indian Fertility Society, past president of the Thrissur Obs and Gynae Society and convener andrology of SIG Indian Fertility Society. His special interest in assisted reproduction, male infertility, minimal invasive endoscopy and ultrasound. Without further ado, may I request you now, Dr. Venugopal, to please present your presentation and enlighten us on this topic. Thank you.
Respected Chairperson, sir, thank you very much, sir, for that wonderful introduction. I want to thank also the Rewari Obs Society, Dr. Seema, Mittal, Alka, Yadav madam, for this opportunity to be part of this very wonderful CME and so aptly titled Filling the Lacunae. So what I thought is, it's male infertility, and that is one of the biggest lacunas in the treatment of infertility. I think many of us would agree to that. There's no doubt about it, because From whatever I see, especially in our part of the world, and I'm sure in the wherever we practice, the male is often neglected. We like to focus a lot on ovulation induction. We like to talk about PCOS, endometriosis, all these things. But somewhere around the way, the male is sometimes forgotten. So just a few tips or take-home messages from my side regarding male infertility and how we go about it. So there's this common misconception in every I've practiced in Pune, I have practiced now in Kerala, I go to Tamil Nadu, everywhere. It's a common misconception that infertility means it's all about the female, when the truth actually is male infertility alone or in combination with the female actually accounts for at least 50% of the cases. And so many aspects of the male infertility, they remain hidden just because of the reluctance to focus on the male. Like the reluctance is there to talk to the male, sit down, ask history, examine the male. So the male is often forgotten. So it's important, and to evaluate the male for every gynecologist, very important to stay updated regarding the conditions that cause infertility, what we need to do for the male, at least the minimum least that we need to do, and what treatments we can offer. We need to know as gynecologists some of the causes of male infertility, extending right from the central causes, from pituitary, hypothalamus to the peripheral causes. Now, this is one area where, we can't spend much time, but the focus of this slide is just to say that, there are a lot of causes of male infertility, though 34% remains unexplained, but varicocele, sexual factors, very important. It's very important that there are a lot of causes of male infertility. So what is the basic role of the gynecologist and what is my message for the day? First one is, you must spend time for the male. We must, every gynecologist must, many often what happens is it's the female partner who initiates treatment, goes to a gynecologist, the gynecologist often a lady, and then, for some reason, there's hesitancy in asking simple questions in history. The biggest questions are things like coital frequency, is that part of things okay? It's very important, there's this tendency to send the male just to a urologist for urological examination and say, you go there. But then, a preliminary semen analysis, does a male not deserve a preliminary semen analysis? Definitely it should be ordered before referring the male. And then additional tests, you may leave it to a specialist if you're not treating, but you must know that there are few additional tests. And one last message is also there that, nowadays there are a lot of genetic contributions to male infertility. Don't forget that. And then also, start looking at the patient, ask history, look at the gait of the patient, look at the hair pattern on the male. Sometimes these may be big giveaways. I've seen patients who have been treating for infertility 1 complete year for ovulation induction, all tests done without a single semen analysis being done because the male just says that everything is okay. Let's not have these things, right? And especially after COVID, this coital problems are very common, in our now era of stress and all these targets and all these things. Coital problems are very common, most less spoken about. So history taking is very important. See, we are not going to details of this slide, but we should know some things we shouldn't miss. Like I said, coital history, sexual dysfunction shouldn't be missed. History of previous surgeries. Ask simple questions, is there a swelling on the testes, those kind of things. Nowadays, you should ask history, youngsters, whether history of drug abuse. Let's not forget this. Ask history of alcoholism. Ask history of binge drinking, going to the gym. All these few, questions may sometimes be a big giveaway in this. So the point to be made was that, history taking, and don't just refer the male away. Ask history to the male. Spend some time with the male, especially sexual history, and this definitely need to be asked. My next question is, my next point to be made is about semen analysis. Very often we find that the female partner has hundreds of investigations, but the only document that the male possesses is a semen analysis. The problem with semen analysis is, you should do it from a reputed lab in the sense that a laboratory which does, and it's used to doing evaluation of the semen. The technician there may take a little bit of trouble to find out, whether the technician is acquainted to doing a good semen analysis. Makes a lot of a difference, because even though there are automated semen analysis available now, Not many labs invest in automated semen analysis and things like that. It's just a technician in the lab who's, looking under the microscope. So that person has to be trained, because semen analysis is a very, very, very critically important document. I think all of you will agree with that. It provides information about the entire functional status of the testis, the tubules, epididymis, the glands, everything. And then most importantly, its results are often taken as a surrogate measure of the ability to father a pregnancy. So in this semen analysis, what we do in our centers, we have benchmarked a few labs around our clinics, our clinic and in our city. So we know that, okay, if this is a report from this lab, it's likely to be reliable. That sort of benchmarking should be there until, we evolve a very standard method of semen analysis across the board. So this is very important. I will always look at the report as to who has done the semen analysis. Very important. Now, when I look, I must understand that the semen analysis alone cannot be used to predict male infertility. And you can't look at the semen, even the new WHO criteria, they talk about semen analysis and they say, it's not saying that, you have less count, you won't have a child. No, that's not the thing. Similarly, your count is normal, so you're perfectly okay. Both ends of it are bad. Okay, the semen analysis is important, but it cannot be conclusive in the prediction of male infertility. It's very important. You have to understand that in approximately 6 to 27% of infertile males, the results are normal. They won't be a problem. Okay. And then also you must know that we are doing semen analysis. References are from a WHO manual, which use select population subsets, so value what is available in, say, New York, maybe not be what is available in some city in India. So these are all important things, variables, external variables, which affect the semen analysis is there. There's of course biological variability also. If you do 10 semen analysis of a male in 2 to 3 months apart, you will find radical difference of them. That's called biological variability. There's environmental variability. So many, don't look at a semen analysis and give a judgment. Don't give a judgment. It's very important. Okay. So, the reference analysis values in the US, they differ. So it can be considered normal. These are all small things to understand. Now, another thing to understand most importantly is when you look at semen analysis, it's not just the count that matters. This is the biggest mistake we make, that we just tell your count is okay. Finish. Okay, you're all right. Count is fine. There's something beyond the sperm count. There's the importance of volume, odor, viscosity, pH, even basic things people forget. Low volume sperm count can give you low volume. So you should look beyond the sperm count. Look at the motility, morphology. All things are important. Look at viscosity. Everything is important. So my talk, see, we are not getting stuck on one particular thing like hyperviscous semen or anything. The message for the day is appearance of the sperm can give you an indication for some illnesses. Volume can give you an indication of some problems, of obstruction somewhere. Similarly, your pH. All these things are important. And then your liquefaction and viscosity is sometimes forgotten. Nobody looks at it also. But a hyperviscous semen sample can be a pointer to infections in the prostate or seminal vesicles. So you learn to look beyond the semen analysis. This is my second point. Remember the first point I said, always examine the male, always take history of the male, don't just refer. Second is do a good semen analysis. Look beyond the sperm count. Look at morphology. See morphology, look at this sperm count. For example, if you look at this thing, all the sperms are, many of them are having abnormal heads and this thing. So morphology is important. We have to look at morphology. Tell the patient that there's a problem like this. We need to look beyond. So obviously the patient will be curious as to why it happens. So then you have to, when you see there's a lot of morphologically abnormal sperms, then you have to think about infections. Is there varicocele? Is there diabetes? What is the reason? Only when you know and you look at it, then you come to know certain things. Similarly, I have seen amazing it is that there's this patient who came to the clinic. She had a lot of sperms. The husband had a lot of sperms here, but not a single sperm was moving. They were all motile sperms, and then the patient was subjected to 5 or 6 IUIs. Can you believe it? 5 or 6 IUIs without even seeing that almost all the sperms are dead. So you should know that when the sperms are not motile, you should know whether they are viable or not viable. So motility is another thing. Are they dead sperms or are the sperms capable of fertilization? Should we offer IUI or some sort of treatment to this patient? It's very important to look at these kind of things, why there's so much non-spermatozoa cells. So you should spend some time, and then, you find sperm reports saying leukocytospermia, 8 to 10 reports. Nobody even looks at it to find out whether they're really infection. And if it's really infection, we must take some trouble to treat that infection. That is my thing. So, I've made 3 points in the middle of my talk. First is that, the male deserves better evaluation. Second is he needs a good semen analysis done. The third is when you look at a semen analysis report, then, look a little bit beyond only the count. You look at the other aspects of the semen analysis also. It's very important. Now, once you finish that, basic evaluation, next is, medical to some other clinician, or even if some prescription is written to them, prescription will have 4 or 5 medicines. It will have some kind of clomiphene in it. Then there will be an antibiotic. Then there will be a medicine for improving count from some allied specialty, some clomiphene written, some medicines like that. That should never be our approach. If we are going to prescribe for male infertility, follow this simple protocol: examine, investigate, and compartmentalize. Why, I would say that it's very easy to do this, because when you do this, you will find that most of your patients will fit into one of these 3 categories. It will be either a hormonal problem, with a low count. You have to just apply your mind and see, is this a hormonal problem that's causing a low count? Is there some infection that's causing a low count, or is it some oxidative stress or things like that? Idiopathic male infertility pattern, is that the one which is the problem? So, but always compartmentalize. Never have blanket prescriptions for male infertility. It's a very horrible thing to do. This is very important. Then there's some specific messages, that when you think about hormones, am I thinking about an hormonal etiology for decreased count? Then you must remember that testosterone is the king in spermatogenesis. Whatever treatment you do, you are trying to increase the intratesticular testosterone. Mind you, you're trying to increase the intratesticular testosterone, not the serum testosterone. So even if you give your letrozole, or even if you are going to give your clomiphene, all these medicines, even if hypogonadotropic, you are giving gonadotropins, what are you trying to do? You're trying to increase the intratesticular testosterone. And also, this testosterone eventually converted to estradiol. So, people talk about testosterone estradiol ratio and how it is relevant. And it's relevant in this context. But testosterone is the king. And it's intratestosterone, not your serum testosterone levels that matter much. Okay, this is very important to understand. Why is because the next slide is more important. Just because your problem is in the testosterone and you want to increase the testosterone, never give testosterone as treatment for decreased sperm count. This is the next important message to the general gynecologist, that testosterone itself should never be a therapy for male infertility. Why? It's going to cause reverse feedback, and then ultimately it could result in azoospermia. That classical example is given, also in the gym. When in the gym, the young males go and take testosterone, supplements. What happens is then there's a rebound fall. So it's not the oral testosterone. Never give exogenous testosterone for treatment of male infertility. This is very important, because I remember when I started my practice, it was a common practice to write testosterone. There are different brands that were available, but ultimately they're disastrous. Similarly, now what is seen is a lot of young people going to gymnasiums and all for bodybuilding. They take supplements and then taking of medicines like testosterone and its derivatives. I don't know whether you heard about it. Medicines like Aquavira are commonly taken, and then you give these medicines, and that's disastrous for the male. It's very important to understand. Now, similarly, I was mentioning, so what do you do then, if the testosterone levels are low? There are other ways. I told you testosterone gets converted into estradiol, and there's a testosterone-estradiol ratio. So if the estradiol is getting more, you can decrease that estradiol by, giving these aromatase inhibitors, or, you can give medicines like clomiphene to increase the luteinizing hormone and subsequently to increase the intratesticular testosterone. So basically, you avoid testosterone from outside, but find other ways to increase the testosterone. It's very important. Next is the infection compartment. There are few important facts that you need to remember with respect to infections. One is any febrile illness can depress the sperm count for 4 to 6 months. Very important when you take history. And nowadays you have so many viral infections and all circulating. It's very important. Similarly, this chlamydia, things like that cause non-specific epididymitis. That's why it makes sense that if you sense examine the male, you find tender epididymis, you can give a course of doxycycline or something like that. It responds because culture is going to be negative, but chlamydia is likely to be the culprit. Similarly, we all like to talk about mumps orchitis. We know that it usually occurs 4 to 7 days after parotitis. Any reason for male infertility? We like to ask you, do you have mumps? But we should remember that only 5% of men with mumps orchitis will become sterile. Okay. Similarly, we need to remember when we give medicines for infections of prostate, prostate has very less blood supply. Very few antibiotics concentrate in the prostate, and hence prostatic infections are very difficult to treat. These I put these few because these are a few very relevant ones for us in our contemporary practice. Similarly, this question always asked that if you have leukocytospermia, what to do? It's very easy if you remember this, not always culture is required, very low level leukocytospermia, you could give empirical antibiotics, but if culture positive patients are there, start antibiotics as per culture reports, and culture negative patients with proven leukocytospermia treat with anti-inflammatory therapy and frequent ejaculation, okay, because antibiotics are not going to be beneficial and you will end up giving the patient antibiotic resistance. So, but evaluate. Remember to evaluate for genital tract infections. MAGI, it is called male accessory gland infections. From there, we move to this entity, idiopathic and also known as male oxidative stress infertility. This is a very novel concept. Previously it was not so much existing, but now a lot of research has been done, and then male oxidative stress infertility has been introduced as one of the reasons. It's called MOSI or this thing. It takes the level of both oxidants and reductants. It's known as one of the reasons for low count, especially in patients with varicocele, patients with male accessory gland infections. You find this. So what question is, if you have oxidative stress infertility, you suspect, then what antioxidant should be given to these patients? This is the question always asked. Antioxidants are beneficial in many ways. They improve motility. A lot of these studies are there that they suppress ROS production, reduce the DNA fragmentation, improvement of viability. All these things, a lot of studies are there, and a lot of antioxidants are there. Coenzyme, L-carnitine, N-acetyl, cysteine, lycopene. You can use. I use many. I use vitamin C. I use vitamin E. I may use lycopene. Depending upon what the patient can afford is my main area where I look. I know that oxidative stress can cause infertility, but what I use, I sort of I don't have blanket prescriptions as such, but then I do give this because I remember this one thing, that there's something called antioxidant paradox also, which also not very good for the patients, because we need some amount of reactive oxidant species in our body for some functions of the body. So too much of use of antioxidants is also not a very good idea. This is also important, So, we came ahead from the necessity for evaluation of the male. Then we came into semen analysis. We discussed looking beyond analysis. Then we discussed a rational approach to oligospermia or decreased in male count, categorizing patients into your oxidative problems, into your hormonal problems, or into your infectious diseases. No blanket prescriptions. That should be the message for the day. No blanket prescriptions. Categorize and then prescribe. Now, this is a very important thing, the genetic aspect I was mentioning earlier. Every gynecologist needs to know that the more severe the problem, the higher incidence of genetic issues. Like, as you go from normozoospermia to azoospermia, the frequency of genital anomalies just goes on increasing. So there is definitely, think about genital factors, ask history whether there is male infertility in the family, and do karyotyping. We do karyotyping for azoospermia. We do karyotyping nowadays even for severe oligozoospermia. You don't have to go for very advanced difficult patients, but for azeo and severe oligo, you need to do some kind of genetic testing. This is important, and every gynecologist needs to know. Another message is azoospermia is not synonymous with sterility. More important to understand is all reports of azoospermia need not be azoospermia. Whenever you give a semen analysis report, always ask for a centrifugation of the sample, because many semen, almost 20% of azoospermia ultimately turn out to be azoospermia. It makes a huge difference. Treatment for azoospermia has very much developed, and it's no longer means donor program, and there are a lot of options available for azoospermia patients. Another issue which gynecologists always is, if you can't offer medical therapy, why not offer surgical therapy? So it's basically very crime to do an ultrasound on all male infertility patients just because they have a low count to diagnose infertility. The varicocele can be diagnosed by a simple clinical examination, and that is the most reliable. And every varicocele does not need surgery. Surgery needed only for couples with size, FSH levels, and palpable varicocele. Nowhere does an ultrasound come in the diagnosis. After you excluded other causes, and the female factors are normal, especially look at the ovarian reserve of the female. So never decide to go for a varicocelectomy surgery just because you saw a varicocele, that to a subclinical one, on an ultrasound. This is the next important message for every gynecologist. Don't try to do something because the patient wants something to be done. Next is the, we must remember, but this is not the DNA sperm. There's a DNA of the egg also. So if there is minor, DNA strand breaks in the male also, the DNA of the female or the oocyte is having ability inherently to cover up for or correct the problems that are there seen in the male. So, just because DNA fragmentation does not mean that you should, think too great about it and prognosticate. There are definite indications for assessment of DNA integrity testing. Just because some lab comes and tells you, and this thing you should never do. See, this is very important. So, if there's infertility and everything looks normal, then you may think, is it problem with the DNA? If there's recurrent pregnancy loss, you would do that. If there's recurrent implantation failure, you would do that. So these are few things, the role for the DNA integrity assessment is limited by and large. Most important probably is this, that, counseling of the male infertility patients is very important. Top priorities where the gynecologist plays the role. For that, we need to be updated regarding all these things and, take enough information and try and help the patient. So that was my basic, few points or tips. If you want to go fill the lacunae in male infertility, a little bit of knowledge of these points that I mentioned is important for psychological consequences, especially diagnosis of male infertility. Sometimes, you diagnose male infertility and then the male partner just dissolves, he even refuses to get his wife treated in any way. And so that's very bad, this thing, So first person to tackle this very effectively is the first contact, which is usually the gynecologist. Hence, my presentation. I hope that, I made a few points without, taking too much of a strain. And I hope the time that you spent was worth listening. So thank you for the opportunity once again. And
Dr. Venugopal, thank you so much for delving into a domain which I call it hitting beneath the belt. It is absolutely essential. When, as a gynecologist, we are dealing with a lady, let's all remember that 50% of the onus is lying solely with the male partner also. So thank you so much for deliberating on this topic. Yeah.
Thank you, Dr. Venugopal. It was such an eye-opener. And blanket prescriptions are as common as dentists treating dermatology patients. So in male infertility, we usually go with whatever the pharma company people come and tell us, give this, give that. So I think after your lecture, we would be more alert to go for infection treatment or just find out grossly what is the defect and not putting the patient to unnecessary investigations like ultrasound or surgery. I mean, I feel it's almost useless. So thank you so much for this presentation, and over to Deepika ji for the presentation. And I hope Dr. Anubhuti, our lovely secretary, has joined to introduce the next session. And Deepika ji, I want to tell all our audience that we will be just projecting our information for the Nimrana upcoming visit. That's Infertility Haryana chapter IFS meeting. And it's an exotic place, and February is the best time. So Dr. Venugopal, Dr. Bela, and all our audience, we would like you all to join. It's a joint initiative of Rewari Society and Indian Fertility Society. Over to Dr. Deepika.
Thank you very much, Dr. Seema, Mittal, and Dr. Venugopal. So this is our product for which a new launch product. for which we have our marketing group manager over here with us, Mr. Hitesh Verma. He'd like to address the gathering.
Yeah, thank you, ma'am. With the trust and care of LycoRed, we have introduced one more brand. So in male infertility, we have either tablet having N-acetyl ISHMG as a carnipure, then CONVENOR 100 mg with lycopene 2.5 mg and lycobate, which is providing 100% of lycopene to the patient, with zinc 12 mg and selenium 40 mcg tablet. So the LycoRed-M in the system in India is having NC along with L-carnitine L-tartrate with coenzyme Q10 and lycopene. So we are promoting this brand LycoRed-M in oligozoospermia, acinozoospermia, teratozoospermia, oligoacinoteratozoospermia, and idiopathic male infertility. And usage is as per the recommendations, one tablet OD for 3 to 6 months. So looking forward for your support for this brand LycoRed-M in male infertility cases. So this is the first time India brand which we have launched after 20 years of legacy and trust and care of LycoRed. Thank you, ma'am. Thank you.
Thank you, Mr. Hitesh. And over to Seema ma'am now for the Nimrana event, ma'am.
So this is the event which is, everybody is invited, Haryana chapter of IFS, and this will be a one-to-one interactive session, and it is just a new experiment where we are having limited number of participants, and I feel knowledge is like joy. More you share, it multiplies. So we will like all our participants to share their knowledge on this platform. And Nimrana Fort Palace it's a beautiful location, and weather in February is just awesome. And you all are invited for the interactive and entertaining meet on 10th and 11th February. And Nimrana Fort Palace is on Delhi Jaipur Highway, and it's one of the prime properties, and one who comes to this will remember it forever. We will like to make it memorable. So thank you, Deepika ji.
Now we carry on with the next session. The chairperson for this session is Dr. Anubhuti Mohan Singla. She is the secretary, Rewari Obs Gyn Society.
So we go with our topic, that's managing difficult embryo transfer. So this is our attempt to fill in all the lacunae and just come to a conclusion. And this is very important talk which we're going to have today about embryo transfer. So despite major advances in assisted reproductive techniques, the implantation rates remain relatively low. Successful implantation requires viable embryo, receptive endometrium, and an optimal transfer technique. Various IVF steps proceed successfully up to ET stage in about 80% of the cases. They say that when you are climbing up a tree, you are very, very careful. While getting down, you are alert, but mishap happens always in the lowest 20% of your journey because you become careless. Same thing happens when we are going for embryo transfer. A good embryo makes us confident, and somewhere we fumble. Unfortunately, most clinicians consider the ET technique as a simple procedure. To them, it only means a simple task of inserting the catheter into the uterine cavity and delivering the embryo. But it's not as simple as it appears. Easier said than done. So the ET techniques can affect our IVF result. It has been proven that the pregnancy rates differ significantly among different individuals performing within the same IVF setup. So how alert, how careful, and how focused you are with the embryo transfer will decide your results to a great extent. We need to standardize the protocol for the ET techniques. In a survey of 80 IVF practitioners, standardization of ET technique was considered the most important factor influences the success in IVF. And poor ET technique may account for as much as 30% of all IVF failures, and that's significant failure rate. Next. So what are the steps to be taken before embryo transfer? So before the start of IVF cycle or immediately before the actual ET, in a retrospective study of 289 ETs, there was significant difference in the ongoing pregnancy rates when dummy ET was done before IVF cycle compared to performing it at the time of retrieval. During dummy ET, it's very, very important that we carry out dummy ET. And nowadays, whenever a patient has come to us for IVF, we are in a haste to start the patient on the cycle without even doing the basic test, because we know some other person will come and take away our patient. And that's very, very wrong practice, because such an emotional and financial burden on the patient. So dummy ET is very, very important, and it should be done in one cycle, and IVF should be taken in the subsequent cycle. So during dummy ET, length of the uterine cavity should always be measured, and most important is its direction and degree of cervico-uterine angulation. We become experienced, and over a period we start just missing out on few things because we overlook them. Always start as if you are a beginner in every case. It's also a good test to choose the most suitable kind of catheter. So there can be problems if you've not done previous workup. There can be pinpoint external loss. There could be a cervical polyp or fibroid you have missed out because your work was not complete. Or somebody else's patient comes to you. Sometimes, half stimulated patients come to you and they say that they are undergoing IVF. You just take up the patient straight away for IVF, not realizing that your basic homework has to be done. Stenosis cervix from previous surgery or congenital anomalies. So if cervical stenosis, which is very, very important for difficult transfer, it is diagnosed, then it is advisable to perform cervical dilatation before starting the IVF cycle. Earlier, we were using laminaria tent, and that was very, very useful in dilating the cervix. Nowadays, I don't find it in the market. Next. So why is it difficult to transfer? As we talked about the angulations, if we have done the workup, we have done the sounding, examination, dilatation, then we can really go for a smooth transfer, because cervical stenosis, acute angle of the uterocervical portion, and unexperienced operator. I will say even the experienced operators make a mistake, because at times the overconfidence kills. So as I said, you start as if you are a beginner, and doing a case for the first time will always save you of all the problems. So what else we have to done? We have to do our initial assessment, and then ultrasound. You cannot be an infertility specialist without an ultrasound machine with you. You cannot rely on radiologists to give you the findings. You have to be really good in your own ultrasound, and it's a precise method to measure the length of the uterine cavity and the cervical canal. And you can see the angle also. You need to be experience teaches you, but once you are keen to learn, you can find out practically everything on ultrasound. It's essential in diagnosis, presence of any fibroids, any endometrial polyp, or any other abnormality or encroachment in the cervical canal. So the acute degree of anteversion, retroversion, anteflexion, or uterocervical angulation and stenosis are most difficult reasons, which can be diagnosed to some extent on ultrasound. Scarring of lower uterine segment and cervix, and distorted anatomy by fibroids or previous surgery or congenital anomalies can all lead to difficult transfer. My favorite is hysteroscopy. In our center, we as a routine do hysteroscopy for all the patients who are coming to us for IVF, and that saves us from lots of problems. We know on first instance, we have our anesthetist who is helping us for a smooth dilatation, smooth entry, cavity assessment, and definitely the success rate increases. So if we go by literature, it's for or against hysteroscopy, but I would recommend that hysteroscopy should be done as long as you have the endoscopy facility at your center, because your patient, you have to assess yourself. Somebody else's assessment doesn't really help you to the great extent. There have been so many studies which say that hysteroscopy can be regarded as first-line procedure in all infertile women, especially during the basal clinical assessment of the couple, when assisted treatment has not been started yet. And at times there are additions, and you just done a diagnostic hysteroscopy, or there's a small polyp which you remove, and the patient conceives spontaneously also. And I see these all these basic etiquettes missing from the youngsters nowadays, because everybody is in just a haste to perform IVF. It's not the number that matters, it's the quality that you give to your patients, and the blessings that you get in return are important. So this is another study which says that hysteroscopy in asymptomatic women prior to their IVF cycle could improve treatment outcome when performed before commencing the IVF cycle. And and some problems that we come across could be a false passage in the cervix, and sometimes it happens that you have done all basic work, cervix is getting dilated easily, and when you take up your patient for IVF, your cannula is not going some in the proper place. So maybe we are creating a false passage with acute angulation, or it's a tortuous cervical canal with a fibrotic internal loss, where without endoscopy we just cannot reach to a diagnosis, or there are severe fibrotic internal loss, or there's a fibroid which is very close to cervical canal. So here the hysteroscopic surgeries really help, and literature says that hysteroscopic cervical canal shaving is a new therapy for cervical stenosis before embryo transfer, and in difficult cases, sure, we can try this. Then Versa point was in vogue for quite some time, and there has been a series when unusually difficult embryo transfers have been overcome, and there is improvement in vitro fertilization transfer outcome, and that has improved the pregnancy rates also. Then transcervical placement of MALICOT catheter after hysteroscopic evaluation has also been documented to provide easier entry into the endometrial cavity for women with history of difficult insemination or embryo transfer. Honestly, we don't have any personal experience, but looking at this is a very cost effective and a simple procedure, and maybe somebody from the medical college could try on these procedures. And the study said that hysteroscopic evaluation and placement of a MALICOT catheter is a useful technique that allows easy entry into the cervical canal. And office hysteroscopy in difficult embryo transfer, or as I said, in all our IVF patients or infertility patients, normal infertility patient, with a certain criteria, we go for diagnosis hysterolapro. And for IVF patients, as such, hysteroscope is mandatory. And office hysteroscope is a very simple instrument, and it's a very small procedure, and which is very, very helpful. Hysteroscopic morcellator is another to be used in overcoming cervical stenosis, and this morcellator allowed safe and direct entry into the uterine cavity, and this is an alternative method for overcoming severe cervical stenosis. And in the end, I would like to know from our panelists also what is their experience. In my 20 years of IVF practice, at least I have found 3 or 4 cases of severe cervical stenosis, which, to be honest, we could not manage, but now we have all these modalities which really help us. So this is another picture. So now coming to the procedure, when we are putting the embryo, what all things we have to look at. So first is the cervical mucus, which can seriously impair a proper embryo placement, and plugging of the tip of catheter can cause embryo retention. So these are simple basic precautions which we have to take, and they help us in making our embryo transfer technique very, very simple. And the various studies have been done where authors have reported that embryos were much more likely to be retained when the catheter contained mucus or blood. And removal of cervical mucus prior to ET significantly improved the pregnancy rates. So from where we know that mucus comes from cervix, but at times after transfer, we see there is blood on the tip of our outer or inner. Blood on the inner catheter, if there is blood, we say it's a poor prognosis and our patient will not conceive. Blood on outer sheath can be at times because of the false entry, or maybe our outer, it should not go beyond internal os. We go to the external os, internal os, and it is just at the internal os. If we go far advanced, we can touch the endometrium or enteromyometrium, from where the blood can come, and making our ET difficult. Sometimes everything is fine and suddenly you realize that your inner is not going in. Then you have to just withdraw your outer little bit or rotate it a little bit and then move on. So various studies have said that removal of cervical mucus does improve implantation rates. This is another study which shows that effect of blood and mucus does affect the success rate of IVF. Another very important topic which we will be discussing in our panel also, now that so many IVF specialists say that there is fluid in the endometrial cavity, and whether it should be removed or not. Transfer which was not there when we were assessing the patient during of follicular development, we have to find the reason, because it could be because the hydrosalpinge is polycystic ovarian disease, or that we can rule out earlier, but it could be subclinical uterine infection also. So I would suggest that embryo transfer should be postponed in case you find any fluid, though it gives lots of trauma to the patient. Patient at times has, feels it's a wastage of time, energy, money, and emotional trauma also, because some of the patients will come, it's a particular time that they want to conceive, but recommended would be that you postpone the cycle, or if it's a month, then removing the fluid with an embryo transfer catheter immediately before embryo transfer may be a successful method of treatment. This is how we go for embryo transfer. Cusco speculum is put. We have already done the workup. We have to keep our sheet ready where we know this is the uterocervical length, and this is how we have to place our ET catheter. So what all can go wrong during transfer? There can be disruption of endometrium, as we have already talked. And another very important point is that there can be uterine contractions can start if we have gone wrong and you've touched the uterine fundus, and we might deposit embryos in a suboptimal location, or embryos might get damaged during the procedure. So what are the potential negative factors that will affect the embryo transfer? So let's talk about uterine contraction. Initiation of uterine contraction can lead to immediate or delayed expulsion of the embryos, and it's a very, very big concern in ART. Though again, there are different schools of thought, but definitely uterine contractions have to be stopped. And in a study by Woolcott and Stenger, it was observed that embryos can move upwards as well as downwards. So it is possible that they can get expelled partially or totally. And various studies have been done that if you touch the fundus, the bubble which was put in the uterine cavity has been expelled. So it's crucial that catheter passes through the cervical canal and internalized to the uterine cavity, and we have to use a very soft catheter which can be unnoticeably curved inside the canal. There are various studies which say that touching the fundus with a catheter initiates strong random uterine contractions. Place your embryo 1 centimeter below 0.5 to 1 centimeter. Some take it as 1 centimeter below fundus. We take it as 1 centimeter. We always transfer 1 centimeter below fundus. We already have our uterocervical length measured, and we always do it ultrasound guided, and we know where we have to put our embryo. Embryo transfer should always be done under ultrasound guidance only. Without ultrasound, there are chances that we will miss the proper placement. Mid-cavity placement is ideal because various studies have been done which show that wherever you leave your embryo, the sac is formed there only within 1 centimeter. So it's a routine procedure, and the fluid is very important. How much fluid we are putting? If there's too much of fluid, then also the embryo can get dislodged. So depositing the embryo in mid-fundal area of uterus improve the pregnancy rates. There are other options, that is use of a fixed distance technique has greatly reduced the variation in pregnancy rates, and clinically pregnancy rates are better when using soft catheter as compared to rigid one. And another important point that we need to discuss here is the use of tenaculum. At times the cervix is not accessible, especially when we are doing transfer with the full bladder, semi-filled bladder. The cervix is sometimes taken up and we have to use tenaculum. But it has been found that there is temporary elevation of oxytocin level when we use tenaculum or tissue forceps, and that can trigger uterine contraction. Honestly, in our practice, most of the time we are using sim speculum and tenaculum, and it really doesn't affect our results. So, but one important thing is that technically difficult ETs are associated with reduced pregnancy rates in a number of studies. Difficult manipulations, again, poor results. Next. So how can we improve our embryo transfer technique? So are there any uterine relaxing substances. Our practice is to give Buscopan to all patients before embryo transfer so that we can prevent any uterine contractions if they happen. Serum progesterone levels on the day of ET correlate with the frequency of uterine contractions, and starting progesterone on the day of oocyte pickup to relax uterine contraction was suggested. Sedation with diazepam has been suggested by some, doesn't make any effect on pregnancy rates. Studies have shown good result with 10 milligram piroxicam and significant improvement in implantation in pregnancy rate. Another molecule which has now come into vogue, though it's very costly and not using as a policy in all patients, that is oxytocin antagonist atosiban, and it is very effective, and it has shown significant improvement in implantation and pregnancy rates. Removal of cervical mucus by normal saline or media has shown very good results, and it has improved pregnancy rates. Proper placement of ET catheter, we have talked. Sometimes catheter can get kink inside. So a simple test is you rotate the catheter to 360 degree and you can discover kinking of the catheter. And another is the profound curvature angulation. So you have to check that. Full bladder sometimes helps in removing the angulation, not proven. Then we can use a malleable stylet if it is a very difficult transfer, but a soft catheter always gives better results. And cervical dilatation should ideally be done in patients where you get cervical stenosis, and it does help in easier ET and improve pregnancy rate. So another helpful way is in a cervical stenosis, as we talked, was laminaria tent, and this is to be put before IVF. And then cannulation of cervix under fluoroscopy guidance has also been tried. In the earlier days, rates of embryo transfer, difficult embryo transfer were very, very high, but over a period, the rates have gone down. And in rare difficult cases, transmyometrial surgical embryo transfer can also be done. Surgical ET has been done successfully, which requires no greater experience than that necessary for US guided oocyte collection. After we have deposited our embryo in the uterine cavity, another important step is prevention of embryo expulsion. And screw of vaginal speculum is loosened so that two valves of Casco's press on the portia vaginalis, including the cervical canal. And after waiting for 1 minute, embryos are ejected and the catheter is withdrawn slowly. Speculum is kept in place for 7 minutes and then removed. And this studies have shown improvement in implantation and pregnancy rates following this. Loading of embryos in catheter is very, very important, and 10 to 15 microliter media is taken, followed by embryos in another 5 to 10 microliter. Best results are observed when no air bubble is taken in between the fluid and the embryos. So continuous fluid column without air bubble is recommended. Then sometimes when there is recurrent failure and there is difficult, then hyaluron-rich and transfer media has been used in large randomized trial, and it shows significant improvement in implantation and pregnancy rates. It's a sort of glue, and recently a Cochrane review was performed to determine whether ET medium enriched with adherence compound has an impact on live birth rate, and it did show high rates in hyaluronic acid groups. So sometimes the catheter is retained in the embryo is retained in the catheter, and it occurs most frequently after a difficult ET. And it is important to keep the pressure in the plunger of the syringe after ejecting the embryo. This is very, very, very important. You've done everything at the end of your journey. If you become callous, you are not aware, you might just take out the cannula and you release the pressure, you might get your embryo back into your catheter. So you have, until complete withdrawal of the catheter, we have to avoid re-aspiration of the embryo, and it is advisable to withdraw the catheter slowly after ejecting the embryo to avoid creating negative pressure, and withdrawal of the catheter, withdrawal of the embryo following the catheter, and that's by the capillary action. Bed rest after ET is again debatable. earlier bed rest was recommended 4 hours together, but nowadays the concept is that endometrial cavity is only a potential space and not a real cavity. So ET catheter only separates the opposing surfaces of endometrium, and once you remove the catheter, surfaces reoppose and they retain the embryo. So bed rest, some studies have even shown that after bed rest the results are poor. So we follow that no bed rest after it is required. Then risk of ectopic pregnancy is estimated to be high as compared to normal pregnancy, and it was 3.5 times more frequent with difficult ET than with easy procedure. ASRM guidelines about difficult embryo transfer is that review prior mock or transfer, patient notes for the level of difficulty and tips for guiding the procedure, prepare patient, check the need for analgesia or identification and matching of patient and embryos, use ultrasound guide and clinician preparation, hands wash, latex-free gloves are to be used. Speculum, flush and clean ex-vagina with cotton swab or gauze sponge using media or normal saline. Remove mucus from endocervical canal. Use soft catheter. Placement of catheter tip in the upper or middle uterine cavity 1 centimeter from the fundus. So, to conclude, just few things are embryo transfer is the most crucial step in your IVF cycle, and a difficult embryo transfer reduces pregnancy rate. Ultrasound, hysteroscopy, and your preliminary examination will help in easier transfer. And by hysteroscopy, you can visualize the path of cervical canal and you can negotiate through cervical stenosis. Large number of RCT are required for corrective surgery related to cervical canal. Thank you for your patience and your precious time. So we conclude here, and I hope it was worth and we could share some of the difficulties. So again, to remind everyone, Dr. Jyoti and all my esteemed friends here, that we are having this Haryana chapter meet at Nimrana Fort Palace, which is a wonderful place, and weather is awesome in February, and it's going to be a great learning experience for all of us. So do join us. So let's move to our panel now. Yes, we have Dr. Dipankar Banerjee, sir. Again, we found this webinar had such a big blessing. We found a mentor and a teacher, Dr. Dipankar Banerjee, sir. Special interest in reproductive endocrinology for last 30 years. He's director, IVF consultant, and Ideal IVF and Genetic Center. He's working in international sonography, endoscopy, in vitro fertilization. He's member of European Society. We have Dr. Jyoti Malik, our most esteemed personality. She is medical superintendent KJ Hospital,
Dr.
director.
Seema, we'll save time. We can see the slide.
Okay, so Dr. Rakhi Malhotra, she is director, AS Fertility and Maternity Center, research fellow in Fertility Center, Chandigarh, secretary, Haryana chapter, ISAR. So let's start with our questions. Question number 1. Yes, so we will put one question to Dr. Jyoti, then to Dr. Rakhi, and Dr. Dipankar will be the final authority to say yes or no. So first question, yes. Dr. Jyoti, what do you do when you find fluid in the endometrial cavity on your day of transfer, which has not been diagnosed earlier?
Yeah, I think I just very gently, when I see on ultrasound that there is a fluid, I just remove that very gently with the syringe, and depending on whether if the amount is too much, then we withhold the embryo transfer. But if the amount is say less than 1 ml or so, then we can just aspirate that fluid and can do a embryo transfer if the lining is proper. We can also then send that fluid for culture. Right. And maybe if we have withhold that embryo transfer, accordingly we give antibiotics. We find out what is the cause of this fluid. Maybe it could be there could be hydrosalpinx which we have missed, and or it could be some chronic endometritis or PID, and accordingly we give antibiotics, a good 2-week course of antibiotics for such patients, and then we can do the embryo transfer.
Right. Sir, Dipankar sir, what is your take? What will you tell our audience about fluid in the endometrial cavity?
So at the time of embryo transfer, if I see endometrial cavity is full of fluid, or there is some amount of fluid in the uterine cavity, it is definitely a very difficult thing to get over, and better I will definitely, if there are good blastocysts, I go for freezing. I will cancel the transfer. Then whatever we can see why it was there, then we can aspirate and culture, no doubt. But definitely I have tried this aspiration and then transfer it also, but it didn't work. So nowadays, if any time I see the fluid, then I don't do the transfer.
So thank you for this precise answer, because I have talked to so many seniors and everybody says that we transfer, but I personally feel very sincerely that once you see fluid, there has to be a reason, and it is always in a failure. Like you can't put it's not a fish that you're putting in a lake. So my next question to Dr. Rakhi. Dr. Rakhi, do you have any experience with embryo glue? What is it, and is it what kind of culture media is it?
I don't have any clue. I also want to learn it.
Yes, Dipankar sir, please put some light on this.
I never used it. I never used it, and I will use it, because there are few reports that there are significant improvement in the. But definitely these are all add-ons, and there are lot of conflicting reports. But definitely hyaluronan is one of the thing which is present in the endometrium at the time of implantation and the adhesion and apposition. So there are good reports about that. I have not tried, but I will do very soon.
But there are many, I think there are many just case studies about this glue. Right. And it is not evidence-based, and people, since in cases where there is a recurrent failure, we want to do something extra, and we just ask the patient. It does increase the cost, but then such patients do not mind trying also. So I think it is, but some centers do use this embryo glue, and they claim good results. But since as you said, and as Rakhi has said, I also have no experience personally using it.
Very true, Dr. Jyoti. That's why this platform is, because Dr. Dipankar is one person who is very honest in all the. He's very advanced also. So if he's not using, I can say that nobody in India is using. And there are reports, and we would like to use it's a protein-rich culture media, or embryo transfer, protein-rich embryo transfer media, which are really helpful according to studies, and we need to work on it. Sir, you were saying something, yes, Dipankar sir?
No. There are reports. If this new book came from Spanish people, they have given this some idea about the embryo glue. But definitely what people have said, that it is a sort of add-on procedure, and it has to be some evidence-based, because it increases the cost. So I have no experience about embryo glue.
Yes, sir. For us, like people in B or C grade city, cost is main concern. Be it Jyoti, me or Rakhi, we all have cost concerns in our patients. So my next question to Dr. Jyoti, how many cases of cervical stenosis have you seen in your IVF practice, and how do you go about it?
Let's say maybe 20% of the cases we do encounter a difficult embryo transfer. Maybe 20 maybe would be a little higher figure, I suppose. But I think 5 to 10% of all the embryo transfers definitely end up being labeled as difficult embryo transfers, and managing them, in fact, a mock ET always, when we do pick up, that particular time only I do the just see how what is the angle of the uterocervical angle, and whether the negotiation with the catheter is easy, smooth and all. And otherwise also, depending on the history, whether if there has been any other sort of surgery on cervix, or multiple miscarriages, or DNCs, or theoretically speaking, any trachelectomy or something, or any cervical surgeries, or any fibroid that we see near the cervical canal, that could we then have to sort of at least see that whether we have to mentally prepare ourselves that it is going to be a difficult negotiation. So one can always have a stillet handy, so that instead of a flexible and a soft catheter, you can use that. You can use the stillet and negotiate it if it is not going. Otherwise, as you said, Buscopan pre-IVF also can sometimes give that relaxant effect. If it does not work, then maybe, and if the patient is called a very sort of uncooperative, and because of that we are not able to transfer, and then one can even do it under short GA. Then there are other ways also with one can do a transvaginal transmyometrial approach also. If all these recurrent patient has been repeatedly undergoing these IVFs and the transfers have been difficult, then in those particular cases, I think vaginal transmyometrial transfer is something that can be done. I have not done as yet transmyometrial as it is. And the last but not the least, these days they say that the hysteroscopically, one can do cervical dilatation in the prior cycles.
Right.
And the last but not the least is cervical. You can do a hysteroscopic cervical shaving or something, so that you can
yes, it is there.
remove that extra bit of mucosa. And if your cervix is like tedha meda, then you can make it a little straight. That
Right. Thank you, Dr. Jyoti, for important inputs. So, third and fourth question I am putting to you directly. So, tell us about difficult transfers that you have come across and the managing cervical stenosis.
Question to me?
Yes, sir, Dr. Dipankar sir, because right,
sir.
मैं
आपको बता रहा हूँ what I do in my day-to-day practice is that I come across this difficult transfer very less frequent, very less. What I do, I always advise whosoever is doing IVF, do an assessment cycle and get a history.
Very true, sir.
That's what we do. Doing the actual IVF. And if you do a hysteroscope, and nowadays hysteroscopes are very, I think 3 or 4 millimeter hysteroscope. And I do hysteroscope, and hysteroscopy gives an idea of the uterine cavity. It dilates the cervix, and you get an idea of the cervix, and you are well prepared. Perfect. Second thing, at the time of transfer, suppose you feel there is difficulty cannulating through. If you are good in ultrasound, then the outer catheter should be seen under ultrasound guide till internal os. Stop there. Take embryo in the inner catheter and ask the embryologist to take that embryo in the inner catheter, then negotiate through the inner catheter, outer catheter, internal os, and you can abdominal probe and view proper, then you can actually see where it is going. Sometimes this happens, there are pseudo cavities or false passages where every time this inner catheter goes and you feel that you are inside the uterine cavity, but it is actually bending inside the cervical canal. That is to be seen, very important, because sometimes we even move the catheter outside inner one. There is freely movement if we clockwise or counterclockwise. But if you go inside the internal os, looking through the ultrasound, rarely I used tenaculum or valcellum or holding the cervix. If it is at all required, don't do the transfer immediately. Get entry into the uterine cavity. Wait for 2-3 minutes without holding the cervix. Then take out the inner catheter. Load the embryo in the inner catheter. Then transfer this inner catheter through the external catheter, the sheath, and go inside and under ultrasound guide below 1 centimeter, transfer this. This is the way I do my job.
Precisely, sir. That is what we do, and you are right. If we are following the proper protocol, the chances of getting a difficult case are very, very less. My next question to Dr. Rakhi, there's an emergency, sir, so I might be just missing in between. So, Dr. Rakhi, please tell us something about role of atosiban in embryo before embryo transfer, because so many pharma companies have come with this molecule. So, what will you say about this?
Yes, I have literature also says, and I have also tried in few cases. It really helps atosiban, and in some cases and chosen cases to but I don't use in every case, but in few patients.
Okay, so next question I put to Dr.
Problem
Jyoti.
with
Yes.
problem is Seema, with the atosiban. In which case I should use atosiban? What
Yes.
is the indication of atosiban?
All
Are
cases
you
this is, sir.
all cases?
The pharma company are after our life, madam. Please use. I said
No,
we
no.
can afford this.
No, no,
ये
no,
ऐसी
no.
बात होती है, ये ऐसी बात होती है क्योंकि आप यूज कर रहे हैं तो मैं भी यूज करने लगूं.
I don't use it, sir. But I want to know. I mean, so sir, what are the indication? Difficult cases? No. Hello, Dipankar. So I
No,
think
this thing.
yes, sir.
No, no. If I am not able to make the indication
Right,
where
sir.
it is to be used. So if it is used to
Sir, your
No
net.
problem.
for
Sir, your
indication,
network.
definitely atosiban is
Right.
one of the. I feel so that it is little bit of logic that you use antioxytocin drug. I think antioxytocin drug, so that can help in relaxing the uterus.
Theoretical. It's good. Right, sir. And rest after embryo transfer, sir. Do you how long your patient lies down after embryo transfer in your OT?
Never.
Yeah. So you're right.
But
And
after embryo
yes.
transfer, at least for some minutes, they do rest
But
on the table,
If
sir.
you,
It's more psychological.
they will be on table and they will not listen to you, and they will definitely take rest because there are other people. They will always say take rest, but taking rest maximum more than 15 minutes are no use.
10
And
minutes.
it is evidence based that rest doesn't make increase in the success rate, rather it reduces.
Yes,
So,
right.
Sir, I want to add here ki when we are stuck up with recurrent implantation failure, then we do all the things which are available, like you said that media, embryo friendly media. So that is a place where we use this atosiban, because we want to even if we are having failures again and again, so we want to use something new. That is a place we add this drug actually.
Infertility practice is based on all add-ons, because when we get failed, so we try to find the reason, and then we try to make other processes or other methods available to us to our best extent.
Yes. And even if we will not try the new drug in some cases, and how will we come to conclusion that whether it is
Absolutely.
effective or not?
I totally agree with you.
Thank you, sir.
Right, sir. So we go to 8th question because 7th question has been answered by Dr. Venugopal beautifully. So we have posted the patient for ICSI, and all the previous reports were saying that there are motile spermatozoa, and suddenly you realize that there is no sperm in your aspiration. So Dr. Jyoti, what do you do in such situation?
Yeah, I think one option is that again we ask them to produce the sample. Maybe he has not collected the sample properly, and
a sample where you have aspirated from testicular aspiration has been done.
Okay. So then I think we just do the oocyte freezing. In these cases, if I have not been able to retrieve any sperm from the testes, the only option left is that either we do a donor sample, which the patient one has to talk to them beforehand. Yes. Also, in such cases, maybe we also should have frozen the semen at least one while before also, so that we have additionally, because that day we are doing the TESA or TC. But before that, one attempt we should always make before ICSI, so that we have frozen some amount of tissue there, and from that again we can see if we can retrieve anything. Otherwise, then we have to do either a donor sample after taking consent, or so maybe freeze the oocytes.
Because freezing is not possible in such cases. Dipankar sir, what's your take on this?
We did it today. I did 2 TISA today, and
Right.
one what she has told that I did a TISA 2 years back from Rajasthan patient, and then we was not able to get any sperm. Then we frozen the eggs. The problem is when you go for, I do a lot of male infertility patients and all in TISA and all, but the thing is you should be very clear and written, and if possible then video consent also should be there, that what should be the, if there is no sperm. And second thing, one proposition is that you do TISA and freeze the sample. I tell you, it is not very easy to freeze the sample, and the freezing media is very expensive. We do that also, and we started doing that recently. And the thing is, it happens that sometimes the TISA, during TISA, you don't get any sperm sample. But what I do in my day-to-day practice, I do a very thorough, or myself, as a thorough andrological evaluation. I can talk to on that subject also, how I do andrological evaluation. And I tell you 90 to 95%, not 95%, 80 to 90% of the chances, whenever I feel that I will get sperm, I get this sperm. It is a multi-quadrant testicular sperm aspiration, and very few, you need very few tubules to get sperm. And but it is a very common fact that at the time of TISA, it is not possible that you always guarantee the sperm will be there. If it is not there, take a consent before. Either you stop or go for donor or freeze the eggs. We do egg freezing. In this case, patient took time to give their consent for donor sperm. They came after 1.5 years. We have 12 eggs frozen, 7 revived, 2 blastocysts. Patient got pregnant. 1 blastocyst was good, 5 AA. So this is the scene what happens when you do male infertility practice.
So much for such beautiful inputs, and I think here we conclude our today's most interesting webinar. And may I call upon Dr. Alka if she's there. I would like to thank Dr. Bela for her precious time, Dr. Deepika for organizing this, Dr. Venugopal, Dr. Sunil Takyar sir. Dr. Alka, are you there? Our Vardi president, and I wish to thank Dr. Jyoti and Dr. Rakhi especially for such important inputs. And Dr. Akriti, are you there? So Deepika ji, we thank Team Jagsonpal also. Dr. Deepika?
Yes, ma'am.
We can conclude. We can thank everybody. And on behalf of Rewari Obs Gyn Society and IFS, I thank all my speakers, my delegates, my attendees, and our...
She is, Seema, she is Dr. Ashita with us. And
Okay.
she
Hi.
joined with MS Gynecology, and she has joined as a fellow with us and taking training from me.
So nice. We are getting that benefit online. See. So, right, sir. Sir, please come to Nimrana. Dr. Rakhi, Dr. Jyoti, please come. Sunil sir already agreed. Yes. Thank you. Thank you so much. It was a great
Thank
learning.
you.
Thank you, Dr. Seema, for the invite.
Thank you,
It was a
Dr.
great
Deepika.
webinar.
Deepika, thank you very much again.
Thank you,
Congratulations.
Dr. Dipankar
Nice
sir. Thank you, Dr. Jyoti ma'am, Dr. Seema Mittal ma'am, Dr. Rakhi ma'am, Dr. Venugopal.
Congratulations for the great webinar.
Right, right. All the faculty. So
Yeah.
here I take this opportunity to present before you the progestins that Jagsonpal has. All the progestin ranges available in Divagest, that is natural micronized progesterone. We have SR tablets in 200 and 300 mg, soft gel as Divagest 200, 100 mg injection as Divagest 100. Then we have Divatron, our micronized dydrogesterone, maintain our hydroxyprogesterone caproate injections 250 and 500 mg. We have maintained allylestanol 5 mg tablet, norethistron acetate as Cycloreg CR10 and plain Cycloreg 5 mg tablet, and then Endoreg Dynogest 2 mg tablet. So truly, Jagsonpal, the progestin people. Here, I'd like to bring to you our LycoRed after so many years of being there as plain LycoRed soft gels that we had earlier. We now have brought out for male infertility LycoRed-M tablet with the added advantage to win in this race. Fortified with N-acetylcysteine and CoQ10 and L-carnitine, this will be a great addition to our portfolio, I'm sure, and we request your support for this newly launched brand in male infertility. Do think of LycoRed-M having all these added advantage. This is the first time in India tablet which is having all of these together in one tablet. Then, of course, our Cystelia-M, which is the right combination of 40:1 ratio of myoinositol and dechiroinositol, the right combination for the reproductive health, especially for the PCOS and associated infertility. So looking forward to seeing you again next month in the other series where we will be having more and more of knowledge sharing by Dr. Seema Mittal's initiative. Thank you so very much.
Thank you.
Bye-bye.
Bye-bye.
Bye.
Thank you, Jagsonpal. Thank you, Dr. Deepika.